Academy. And this is our session 2 of webinar series on role of ultrasonography in critical care. So today's session is going to be on critical care echocardiography. For this session, we will have a sort of theoretical class and then followed by real clinical cases and how use of echocardiography in critical care uh, helps you in diagnosis, monitoring, and taking the rational decisions about patients. So before starting this, just a little introduction about us in Easelife Academy. This is me, Dr. Sandeep Agarwal. I am head of critical care at a multi-specialty hospital in Mumbai. I am also teacher and examiner of IDCCM and IDCCN, and I'm also author of MCQs in critical care book and clinical cases in critical care. We also have a panelist, Dr. Florence Almeida, who is senior consultant in Fortis Hospital, Delhi. He has over 20 years of experience in critical care, and he has delivered more than 5,000 lectures. He's also author of book Critical Care for Nurses. We also have in Easelife Academy, Dr. Bhavnish Sabharwal, who is as of now head of critical care in Mata Chanan Devi Hospital, Delhi. He also has more than 15 years of experience in critical care, and he's also DNB training. So this is about Easelife Academy. And for today's talk, we have one very eminent teacher, Dr. Amol Kothekar, who is professor in Department of Critical Care, Anesthesia and Pain at Tata Memorial Center, Mumbai, India. He is also an instructor in WinFocus USLS course. He also has ISCCM fellowship faculty who in FCCU and FCCE, and he has keen interest in POCUS and hemodynamics. And who better than him to teach us about the echocardiography in critical care? We also have Dr. Prashant Zedge. Dr. Prashant Zedge is a professor in the Department of Critical Care Medicine in Bharati Vidyapeeth University Medical College, Pune. And he will be teaching us about the real clinical cases that you may encounter or you might have encountered in your clinical practice. So without wasting much time, I will request Dr. Amol to start presenting his slides. Dr. Amol, share your screen. So Dr. Amol will be joining very soon. He is having a little bit of trouble logging in, and he will join very soon.
So, good evening, everyone, and thank you, Dr. Sandeep, for kind introduction. I hope I am audible.
Yes, yes,
And
you are very well.
yeah, so apology, there was some technical issue from my end, so I had to log out and log in again. So, and as Dr. Sandeep has mentioned, this will be a more of a theoretical lecture because obviously we can't give you hands-on practice on a Zoom meeting. But I suppose most of you are doing some kind of echocardiography by yourself, and you have some idea about how the critical care echocardiography works. So when I say critical care echocardiography, it is about either TT or TE, but done by intensivists, not by the cardiologist or physicians. And we do it for immediate decision makings, and it is a goal directed, problem oriented, bedside, and obviously it is integrated with a clinical examination. So we are not doing echo as a rep and generating a report. That is not our primary goal. Our primary goal is to answer a clinical question. So when we talk about critical care echocardiography, we can do a very basic echo where you have very focused questions like how is the left ventricular function, how is the right ventricular function, is there a cardiac tamponade? Is patient fluid responsive? Is there a hypovolemia? So these are simple basic questions. Whenever you have any patient in the ICU, you are doing echo, you first start answering these questions. And then you can do a more comprehensive assessment where you can look at the cardiac output, you can look at the diastolic function, valvular assessment, pulmonary pressures, and detailed analysis of right ventricle. So when we should do this echo, generally, we do when there is a new patient coming to the ICU. However, we can also do it if there is a hemodynamic instability, respiratory failure, patient in shock, increasing requirement of vasopressors, some issue with the ventilator requirements, oxygenation, when you want cardiac assessment, when you're suspecting tamponade or effusion. And sometimes we use it as a personal guidance when you're doing pericardiocentesis for ECMO cannulations and also for hemodynamic monitoring we do it. So let's start with the one chamber or one question at a time. Let's start with the assessment of left ventricular function. Now, I would like to have this meeting very interactive. So I would request uh, all of you, you can type your answers in chat box if possible. So when I say assessment of left ventricular function, I talk about systolic and diastolic. So in systolic function, when you're talking about critical care echocardiography, so what we normally do, what we assess in LV systolic function in critical care echocardiography. I request participants to type their answers in chat box. So visual assessment of LV function. So Dr. Deependra, you are bang on the target. We don't look at ejection fraction. That's another reason why I asked this question. We are not looking at LV ejection fraction. What we are looking at is a qualitative assessment, or what is known as eyeballing. And when we say eyeballing, we look at the three different layers. We look at the movement of endocardium. We look at the thickening of myocardium. We look at the motion of mitral annulus, and we look at the overall change in geometry of the ventricle. And then we categorize LV function as either hyperdynamic, normal, mild dysfunction, or severe dysfunction. We don't measure ejection fraction in critical care echocardiography.
Shabash Narayan. Mm.
So
Very last one.
I request all the participants to mute themselves, or maybe the host can mute them. Yeah, thank you. So I don't think we need to answer this question. I'm sure all of you know which patient has a good LV function and which patient has a poor LV function here. Similarly, here, when we just look at the LV, we know whether the LV function is good or poor. Similarly, here, so when we are looking at the LV systolic function, contractility gives you a fair assessment. And more echoes you see or do, your more accurate is your more accurate is your assessment. However, can we have something more objective criteria of LV systolic function in critical care echocardiography? So I request participants to put the answers in chat box. What is the more objective way of assessing LV systolic function other than eyeballing? And obviously, it is not LVEF. So somebody answered VTI. That's right. That is a more objective way of assessing LV systolic function. So how to measure VTI? We look at apical 5-chamber view and we open the LV outflow tract. And when we open the LV outflow tract, we put the pulse wave Doppler and we get this waveform. And when we get this waveform, we measure the area under the curve, that is the VTI, that gives us value. LVOT VTI, normal value is 18 to 22 at normal heart rate. In patient with cardiogenic shock, we have a very low VTI of around 12 or less. In patient with hyperdynamic circulation or anaphylactic shock, sometimes severe septic shock, you can have values more than 24. Now, when you're doing measurement of LVOT VTI, it's very important. You should know exactly where you should measure, because if you, so the LV left ventricle opens into LV outflow tract, which opens into aorta, and each has different area, and that's why they have different velocities. So you can see here 3 different waveforms, and you can tell us, you can answer my question here. So out of these 3 waveforms, which one is the correct representation of LVOT VTI? The first, second, or third? You can just put your answers in the chat box, either 1, 2, or 3. So someone has says 1. So what couple of answers. One, I'll wait here for some time because this is something very important. When you are making LVOT VTI, now we say it's a more objective criteria. So we should know exactly where we were supposed to measure, how the waveform looks like. So can we have more answers so that before we move on? So I'll repeat my question. The question is, which is the correct representation of LVOT VTI? Which waveform correctly represents it? You can answer. If the first waveform is correct representation, answer as 1. If it's second waveform, answer as 2, and so on. So here we have at least 50 participants. So at least I think, because this is the most important thing, one of the most important thing in a critical care echocardiography, the LVOT VTI, because that's a quick objective assessment. And if you follow rush protocol, it also gives us a value and which tells us to differentiate between various shocks. And also, since it is a more objective, you can compare and you can follow up. So we are getting more answers. Some are answer 1 and answer 2. I'll give the correct answer. The correct answer is number 2. This is the correct answer. Here, when you say LVOT VTI, you should only have a closing click, as you can see here. If I go back to previous slide, the first waveform is the aortic VTI, which has both opening and closing click. So this is not the correct representation. Similarly, the third waveform has no click, and this is the LV VTI, which is also not correct. So the correct representation is LVOT VTI. That is only a closing click is seen. And when we have this waveform, your normal value is between 18 to 22. So this was about LV systolic function assessment. We can also do LV diastolic function assessment. However, in critical care, more important is LA filling pressure assessment. You are more interested in risk of pulmonary edema and left ventricular failure. So we go for apical four-chamber view and look at the mitral inflow Doppler. We look at measure E and A velocities. We put the Doppler here. And then we use tissue Doppler and you measure E prime velocity. I'm not going to detail of this. You can do it at your own hospital. You can do it practice, or you can attend in one of the workshops where you will see how to measure these values. And when we talk about elevated LA filling pressure, we talk about average E by E prime ratio of more than 14 or absolute E prime value of 7 to 10. Also, we look at the TR velocity, which I'm going to talk later. Basically, when you have elevated LA pressure, it also there's a back pressure change and there is an increase in pulmonary artery pressure, which causes increased TR velocity, and you have an increase in LA volume index. So you can remember these numbers. So this is more important in critical care when we're talking about elevated LA filling pressure. Now I request all of you to please unmute and ask question here if you have any question, or you can type your question in chat box. So this was about the LA filling pressure. Now diastolic dysfunction is a very favorite subject of cardiologist. However, in critical ill patient, this is not very important. More important in critical ill patient is the LA filling pressure. As you can see here, the grade 2 onwards, we have a elevated LA pressure. So basically, we are more focused on this elevated LA pressure rather than the actual diastolic functions. So these are the stages of diastolic function. I'm going to run these slides in the interest of time. Now let's talk about RV function. When we talk about RV function, there are two measurements we do, and we do one eyeballing or a size measurement. So when you look at the RV and LV size, if your RV size is less half of the LV, that's normal. If RV is almost equal to LV, that is abnormal. And if RV is more than LV, it is grossly abnormal. So this is, you can say, eyeballing of right ventricle. Also, we can do in a short axis, we can look at the shape of the LV, whether LV is O-shaped or D-shaped, and look at the septal position. And if you see the systole, here you can see flattening during diastole, which indicates volume overload. And in patients with pulmonary hypertension, you can have a systolic flattening of septum, which is a pressure overload. We can use M mode at the tricuspid annulus and measure the TR TAPSE. And when we talk about TAPSE, the TAPSE value of 17 or less indicates RV systolic dysfunction. The TAPSE is also used for identifying the coupling, which is done in advanced echo. I'm not going to cover that, but I'm just introducing that concept to you. So basically, you measure TAPC in M mode. TAPC less than 17 indicates RV dysfunction. And second is you measure RV systolic pressure. You first look at the tricuspid regurgitation. You put the continuous wave Doppler. You get the waveform, and then you measure the pressure gradient. Here we had measured the maximum velocity of 280, the pressure gradient of 32, and then we added CVP of 5 here. You can either measure CVP or based on the IVC, you can estimate the CVP and add the CVP pressure that gives the right ventricular systolic pressure or pulmonary artery systolic pressure. You can also use echo. Okay, before there are some queries, so should I answer these queries before I move on? I think
Yes,
there are two queries. One was about the where to measure E and A. So basically, E and A are measured at the mitral inflow with pulse wave Doppler. There was another question about the EPSS. EPSS is also a measurement of LV systolic function, but that is not very accurate and it is not validated in critical ill patient. So more validated is VTI. So I will move on to the next. That is the volume status and fluid responsiveness. We look at the subcostal IVC measurements. Make sure you are looking at the IVC and not aorta. Now let's have some interaction and you can tell me out of this A and B, which is IVC, whether IVC is A, B, A plus B or none of the above. So which one is IVC here? We are getting answers A. So I think we all are on the same page. So first one is IVC, the second one is aorta. And why so? Because IVC opens into RA, it have a respiratory variation, hepatic vein opening. And why it's important? Because when the patient is grossly hypovolemic, you can't see IVC and you should not be mistaking aorta as IVC. And you can use a Doppler measurement also if you have any doubts. So this is the IVC and aorta in the same patient. Don't get confused between IVC and aorta. Now, when you have IVC measure, you can visualize the IVC, you can do eyeballing. Now, again, if you look at these three patients, I think it is not very difficult to identify which patient is grossly hypovolemic and which patient is in fluid overload. However, there should not be any intra-abdominal hypertension or pericardial tamponade because these are the pitfalls of IVC sites. So if there is no pericardial tamponade or higher intra-abdominal pressure, then you can use IVC for volume assessment. Similarly, you can use respiratory variation of IVC. So people either use B mode or M mode for measurements. However, B mode is more reliable. And respiratory variation of IVC, you can measure. So this is about the static measurement, that is the diameter with respiratory collapse, which tells about the CVP. And when you talk about fluid responsiveness in control ventilation, you can use cutoff of 12 to 18%, depending on what is your mean value. However, I must tell you that IVC for fluid responsiveness is not very accurate. If you want to actually measure echo for fluid responsiveness, the better methods are using stroke volume, increasing stroke volume after fluid bolus, or you can look at the respiratory variation of LVOT VTI like SVV, or you can use passive leg raising and look at the change in VTI. So this you can see here respiratory variation of VTI, and this can be used for identification of patients which are fluid responsive. Regarding pericardial effusion and tamponade, see you can pericardial effusion. And when we talk about tamponade, in tamponade you can have either RV diastolic collapse or RA systolic collapse, very large IVC, and you have a large variation in mitral or tricuspid inflow. So pericardial effusion is not equal to tamponade. For tamponade, you need to demonstrate these parameters. So sometimes in severe pericardial effusion, you can have swinging heart, and this indicates a massive effusion and a more risk of tamponade. Now, if you look at the hemodynamic profiling using echo, you can easily identify various shocks. You can identify various shocks by looking at the echo. And I think there is one query. So before I conclude my talk, I will answer that query about the IVC. So the question was about IVC, why M mode is B mode is more reliable. B mode is more reliable because many times the IVC is not exactly horizontal, it is at the slanted, and when you put a M mode, you are not cutting IVC exactly perpendicular. So you are cutting IVC in a beveled fashion, and that's why M mode is not accurate. In B mode, you can actually freeze at maximum and minimum diameter, and you can actually measure the diameter. That's why B mode is more accurate and more reproducible. So to conclude, you can use echo for assessment of LV systolic function, where you do eyeballing, or you can do VTI, and you can use estimate LA pressure by using E by E prime, or LA size or TR velocity. You can use RV and LV ratio, TAPSE, and eyeballing of septal flattening. And also you can look at TR velocity for RV systolic function, RV systolic pressure. Volume status, you can use IVC, collapsibility, distensibility, or you can use passive leg raising or LVOT respiratory variation. And you can use echo for identifying pericardial effusion and tamponade. So thank you for your patient listening and your interaction. And I'm happy to take questions if there are.
There must be questions. So we'll wait for some questions.
Few questions I had answered during the talk itself. So
I think you have answered all the questions which were during the talk.
The chat, whatever questions are there in chat box, I have answered. If there are any further questions, they can always ask, and we can address the questions at the end of the lecture.
Sure. Okay, we can always wait for it. I think we can move
I
ahead.
hope whatever questions are answered are they. I'm not sure whether they got my answers. Like if there are any further queries, why EF comes normal sometimes in heart failure patient? Can you elaborate this question more so that?
Hi, Dr. Amol.
Well,
Yeah, I'm Dr. Florence here. Could you just
Hello.
throw light on how to identify pulmonary embolism?
How to identify pulmonary embolism in echo?
Exactly. Yeah, exactly.
So that's a very important question. I think we have a couple of cases also we are going to discuss. But however, I'm going to explain some principles. Number one, echo is generally used for identification of cor pulmonary or RV dilatation. Echo, generally 90% of pulmonary embolism cases, you can't identify any thrombus in echo because thrombus is distal, it is at the pulmonary artery junction or distal, which is a blind spot for echo. What we see in echo is RA-RV dilatation. Also, you can do measurements like 60-60 sign, where you can judge whether the patient has pulmonary embolism or not, whether it's acute PE or not. Of course, there are some limitations of it. Secondly, you can use your linear probe to look at the DVT. And if you have a patient who is in shock, and you have a positive DVT and you have RARV dilatation, that goes more in favor of pulmonary embolism. So I hope that answers your question to Florence.
We will also have a case on pulmonary embolism where we will
Yeah.
demonstrate embolism, how to see it. I think there is another question.
Perfect. Okay. Another thing, Dr. Anmol, can you just tell me that there could be so many confounding factors when we see the IVC diameter of change? Okay. Like for example, if there is regurgitation. Okay, if there is tricuspid regurgitation, okay, how does it affect if the patient has tricuspid regurgitation, how would it affect the IVC assessment to assess the fluid status?
So in ICU, most of the patients, at least, I'm not sure I have an exact number, but many patients will have a tricuspid regurgitation, because that's TR is a very physiological parameter. Now, if you have a massive TR, then your IVC diameter is enlarged. And then that's why your IVC measurement becomes inaccurate. So especially when the patient has severe TR or RAV dilatation or cardiac tamponade, then your IVC measurements are inaccurate. In absence of TR, you can use IVC diameter as a reliable method of fluid status if the patient doesn't have a raised intra-abdominal pressure. Now, in patients with gross TR, a dilated IVC may or may not tell about the fluid status. So you can use other parameters, like you can use LV end diastolic volume index or LV end diastolic area. You can look relative size of right and left ventricle. You can look at the fluid congestion by looking at VEXUS, where you can look at the Doppler of hepatic portal and renal vein. Or you can use any of the parameters for fluid responsiveness. If the patient is on controlled ventilation with no triggering, then you can use either respiratory variation of VTI. And I think in the most of the patients, irrespective of your breathing or a TR, you can, if you want, your question is whether the patient is fluid responsiveness, you can address by doing PLR.
No, my question is very clinical. Actually, what I have seen in my ICU also, and even after this lecture, most of the students, what they do is, whenever they have to assess the fluid status, okay, volume status, what they do is they usually come with the echocardiography machine. They simply put the probe in the subxiphoid area. They measure the IVC, and
Correct.
they don't bother to find out if there are any confounding factors.
Correct.
So,
Yeah.
is it a necessary? I think, don't you think it is a necessary protocol that before the students keep the probe on the IVC, on the subxiphoid area to assess the volume status, first they should check whether there is tricuspid regurgitation, or whether there is pericardial tamponade, or whether there are signs and symptoms of right ventricular embolism. Don't you think that should be ruled out before keeping the probe? Because most of the students, they directly come and keep the probe on the xiphoid process, and they start the examination there and they finish it there, and they make a comment on IVC status, on the fluid status.
Yeah. So in a way, when you are measuring IVC, you are actually measuring CVP, right? So IVC diameter depends on two things. One is central venous pressure, and another is intra-abdominal pressure. So if intra-abdominal pressure is high, IVC size will be low, falsely low. If there is no intra-abdominal pressure is not low, then large IVC can either mean adequate fluid status. It can also mean a patient with very high CVP, which is falsely elevated, like the condition that you had mentioned just now, like a TR regurgitation or pulmonary embolism. So depending on your patient population, you can tailor this question, and you can use this question to address whether the volume status is adequate. Of course, if you are having a clinical suspicion of pulmonary embolism or tamponade, it's always better to rule out these parameters before interpreting IVC size as a fluid status. Absolutely. However, if these parameters are clean, if your pretext probability is low, then you can, at the initial stage, at least you can use this IVC size as a fair indicator of CVP and not the volume status. So I think the same.
Thank you so much for making it clear.
Yeah. So
I
then
think
we
you have
have
answered the question also about poor pulmonary. I think that also suits this question.
there's one question about EF is falsely elevated when the patient is on high vasopressors. So now this is a very important concept that we need to understand, that ejection fraction is a load dependent variable. So whenever you have a patient in septic shock, you may have a elevated ejection fraction because the peripheral vascular resistance is low. So these patients initially may have a apparently high LVEF, but when you start these patients on vasopressors like noradrenaline, then the EF might drop. And that is because EF is load dependent.
Good evening, sir.
Good evening.
Sir, sometimes we have patients who are in heart failure, but they do have that heart failure with preserved ejection fraction. So when we do the echo, it comes around 60%, 55%, but still there is pulmonary edema, they have failure component and everything. How should we look like? What would be our approach of doing echo to such patients? Because ejection fraction looks normal, but patient still is in heart failure. He has typical signs of heart failure. There is pulmonary edema. So, I mean, what should be our view in the echo? Like, how should we assess the echo in those patients? Because if we look at the ejection fraction, that looks normal, but the patient is in failure in the ICU.
So ejection fraction is just one part of the assessment.
Yes, sir.
You say ejection fraction tells you only about the systolic function. It doesn't tells you about the diastolic function. And even in systolic function, the ejection fraction doesn't tell you about the forward flow. Like if the patient has mitral regurgitation, the ejection fraction can be supranormal, but the patient might be in failure.
So basically,
if
sir,
you're,
there is issue with okay, sir, continue, sir. Yes, sir.
yeah, please tell me.
So basically, is it the issue with the cardiac output there?
So
Like
when you talk about perfusion, if the perfusion is poor, you have to look at the cardiac output. If there are back pressure changes, like pulmonary edema, you look at the left atrial pressure, which is measured by E by E prime, LA volume index, and sometimes it causes back pressure changes and you have a high TR velocity. So this tells you, if you measure these, it will give us an idea about LA pressures. So in patient with heart failure with preserved ejection fraction, most of these patients have stiff ventricles and
exactly,
very elevated LA pressures.
Yes, sir. Exactly. Yes, sir. Yes, sir. The stiff and yes, sir. Thank you, sir. Thank you so much. Yes.
Okay. So can we move forward to Dr. Prashant for presenting his cases? If there are any more questions, and maybe we can take questions later on also.
Sure.
So
I think we can move on to Prashant.
Yeah. So my video is disabled.
Sorry,
I'll share
what
this.
is disabled?
Video is disabled. Okay.
Video is disabled. Okay. See. Can you do it?
Yeah.
Yes. Okay.
I'll share my screen.
Okay, Prashant, go ahead.
Is it visible?
Yes, yes.
Okay, so good evening and thank you, Dr. Sandeep, for this opportunity. ECO is at the heart of teaching as well as learning. Every patient is a new patient. So today we'll discuss about the basics of echocardiography in ICU, and I'll take you through some case-based scenarios. What we'll discuss is it important to differentiate the types of shock in ICUs, where to use the echocardiography in ICU, and some cases in various conditions where echo helps us. So I'll just start with the case. So what do you think? What is this? So it's like a 68-year-old female. She is hypertension, IHD, CKD, stage 5 on maintenance hemodialysis. The catheter has been recently, today morning only changed on the internal jugular, and she gives history of loose motion. She presented to ICU with fever, hypertension, and altered sensory. So she's in shocked state. And practically CKD with such a history, it is likely to have all kind of shock. So it is important to differentiate the shock, and it might be the scenario where any of the kind of shock, whichever we feel, could be there. So typical distribution, we don't have much of the Indian data, but overall worldwide ICU data, it shows almost like 2/3 of the patients, they are in either septic or distributed shock. Unless you are working in cardiac ICU or neuro ICU, where primarily will be the cardiogenic shock and cardiogenic hypovolemic, otherwise the carry is important. Important to note, obstructive shock, even though the incidence is less, it is very, very important to identify the obstructive shock, because the treatment and the necessity of the urgency of intervention is very important in distributive shock. So when to use POCUS in ICU? So this was 2024 article which mentioned about the minute bundle. So what does it tells? How to use the echocardiography, how to rather start management in undifferentiated circulatory shock. So echo or ultrasound comes into play at around 10 minutes. It's not like patient comes in shock and you put in an echo machine to that. So you maintain the ABC. You start with your fluids or vasopressors, take the sample for investigation and ultrasound. So within 10 minutes, around 10 minutes, you should have an echocardiography ready, because it's like a stethoscope for the intensivist. So a question to all of you. So you got 2 minutes. You got a 55-year-old patient who has come in shock. So what you will look at first? So you can put it into the chat box. Not able to see the chat box. Sandeep, Dr. Sandeep, I'm not able to. Okay.
D is the answer. One of the answers is D.
Someone said LV systolic function. Okay. So as Dr. Amol said, that EF for an intensivist is rather an outdated term. We use the LV systolic function. And since we know that it's a global assessment of heart, it's not just the systolic function. You have to look at the IVC as well as its collapsibility and the RV also, because everything goes hand in hand. So likely correct answer is D. And in 2 minutes, it is important to go through all of this. Since it's a global assessment, we need to have some protocols about how to go ahead with that. And so there are multiple POCUS-based protocols in shock. So Dr. Sandeep told me that we will have one more session regarding these protocols in managing the shock. But just to summarize, we have common as being used is RUSH protocol. Then we have the, that blue protocol in case of respiratory failure. FATE is little very very compact but inadequate. It's like a FATE cards. So you'll have the cards and you can identify what kind of scenario it is. False, we use it as an fluid responsiveness in sepsis and others. So with this background, can some of people can tell me what kind of cases you see in ICU which requires echocardiography on priority basis? So we'll go through the cases, such kind of cases scenarios. So it's open for the chat. So you can just put in your cardiac emergencies or or maybe scenarios. So cardiogenic shock, okay. Septic shock, majority like septic shock. Can someone tell me which is the important cardiac emergency where your echo will help? And it is important. Okay, obstructive shock.
I personally would go for undifferentiated shock.
Okay. So, Dr. Sadhu will have the discussion about how to differentiate the shock probably in the later states. See, the patient doesn't come with an identified, no, I have got an obstructive shock now, identify and treat me. So we have to identify these things. So let us go with the case. Okay. So this was a real life case we had a couple of weeks back. So this is gentleman, 52-year-old male, post-op knee replacement, day 3, and he had a sudden onset dyspnea and hypotension. So quickly, can someone put in what could be the likely diagnosis? Because he is in shock. So we have to push forward as early as possible. Obstructive shock. Someone said PE, sepsis or PE, very good. PT, yes. So let's discuss about the acute pulmonary embolism. So acute pulmonary embolism, what you see it in is in first and foremost findings are like RV strain. Okay. So RV strain, you can see it clearly. There's an image on the right where LV is likely good contracting, but on the other side, when there is an RV function is abnormal, RV contractility reduces and it enlarges. So when you are assessing this RV function, make sure that you're not foreshortening the view. So RV and LV should lie side by side. If it is not, if you're looking majority on the LV, RV is behind LV, you'll obviously see that RV is smaller. So it has to have a good view where both the valves should open simultaneously, nicely, and then only can compare upon the size of the RV. Then there is as Dr. Amol said, there is an right ventricular strain which can be presented as an D-shaped LV. So when there is an RV pressure overload, it causes septum to be shifted to left, and that will compress on the LV and it flattens. So LV becomes D-shaped instead of nicely round shape. So that is the either result of RV pressure or volume overload. Generally, when there is an volume overload, you can see that D-shaped septum during both systole and diastole. When it is like a pressure overload only, it is during the diastole. So it basically it indicates it is like an hemodynamic instability because now the LV is also compromised. You see, this is McConnell sign, very specific for the diagnosis of pulmonary embolism. So the criteria, the rather definitions for that is the RV free wall is either akinetic or hypokinetic, but the apical motion is preserved because it is usually tethered with the left ventricular apex. So either it might be hyperdynamic or its contractility is preserved. So typically you can see the RV apex is moving inside when there is an when RV free wall hypokinesia is there. So it was rather 2019 study. It showed almost specificity for the pulmonary embolism is 100%, but it is very it's poor for the sensitivity. So it doesn't rule out, absence of it doesn't rule out the pulmonary embolism. So positive predictive value is almost 100% with a negative predictive value is 56, very poor, 56%. So if it is there, McConnell sign, it is likely to be P. If it is not there, that doesn't rule out pulmonary embolism. It can occur in cases if there is an RV infarct also. Then your next step is you check for the TAPSE. Dr. Amol clearly showed you how to check it for. So you get a nice 4-chamber view, apical 4-chamber view of the RV and LV, and you put in an M mode cursor, bang on the lateral tricuspid annulus, and you check for the systolic excursion. So if there is a systolic failure of the RV, that annulus will not move towards the apex that freely. So that annular movement, what you are capturing, you're not capturing any flow movement. You're capturing the annular movement, which will be impregnated in your Doppler waveform, M mode waveform, which will be like a measurement of that and how much annular movement annulus has moved during the systole. So normal TAPSE is more than 17. If it is less than 17, which is like an abnormal, so it is likely to be systolic dysfunction of the RV, which is likely to be acute and in case of pulmonary embolism. Dr. Amol had stressed upon this. You measure the RV systolic pressures by putting the cursor across the tricuspid wall. You get a nice U-shaped view of the tricuspid velocities, and you measure the peak tricuspid velocity. And from that peak tricuspid regurgitation velocities, Vmax, you can calculate the right ventricular systolic pressures. To add to that, the IVC size and its collapsibility will give you an estimated CVP. So you add these values to the right ventricular systolic pressure measured by the TR velocity, and that will give you the right ventricular systolic pressures. Along with it, what you do is you can measure. It's a little technically difficult, but if you practice to identify and get these good views, you will be able to identify the pulmonary acceleration time. So this is the parasternal short axis view at the aortic valve, where you have the RA opening into the RV opening into the pulmonary artery. So you put in a Doppler cursor at the pulmonary valve and measure the Doppler flow velocity. So it will have a start of the pulmonary flow, it will peak up, and then it will end. So what happens if there is an obstruction beyond this will increase it will rapidly flow the blood into the pulmonary artery. So this pulmonary acceleration time, that is from the start of pulmonary flow to the peak, will be shortened. So normally it is pulmonary acceleration time is more than 130 milliseconds. But in case if there is an obstruction beyond that, increase in pulmonary pressure, this pulmonary acceleration time is reduced. So if it is less than 60, it is likely to be because of the high pulmonary pressure. Along with this, you will have an early systolic notching of this pulmonary flow, which is represented in the sideway diagram. So these are the two findings which you can have. It's technically a little difficult to achieve that degree of window, but you can try. And then it comes to the 60-60 sign, which is a little unique about the pulmonary embolism. So what 60-60 represent is TR gradient, that right ventricular systolic pressure should be less than 60 millimeters of Hg, which we have measured from the TR jet velocity and the central venous pressure from the IVC, and your pulmonary acceleration time less than 60 milliseconds. So this is like a dual criteria. If you have both 60-60 sign positive, the likelihood of pulmonary embolism is 94 to 100%. And this is what is the, when you want to diagnose pulmonary embolism, this is jackpot. So if you see a thrombus which is moving from the RA across the tricuspid wall going into the RV, and you have the other features of pulmonary embolism, you don't require any other things to diagnose pulmonary embolism. So this is a thrombus in the transit where it is trying to move from the RA into the RV. So these are the typical signs which can be seen. So what diagnostic value these signs they have in pulmonary embolism? So this was a little older article around 2002, where it says the McConnell had an almost 100% specificity, but very poor sensitivity. You can see it on the graph. The sensitivity was very low, but if you if these patients, in this study, they had the subgroup analysis also, where the patients with known previous cardiorespiratory disease, as we mentioned, that a pulmonary might interfere with the diagnosis of pulmonary embolism. So in that scenarios, if patient had previous comorbidities in cardiorespiratory disease, you have the sensitivity specificity of McConnell's is 100%, while the positive predictive 100%, but specific sensitivity reduces. The 60-60 sign still hold good enough to diagnose pulmonary embolism with almost 90% specificity. And if you have the DVT in the limb along with these findings, so that your diagnosis becomes more accurate along with the cause of your pulmonary embolism. So you do an compression Doppler. So on the image on the left, you have the pulmonary artery and the vein. When you compress, the vein will not get compressed. So that will indicate the clot in the femoral vein. And on the right, you have I've just depicted how the venous system of the limb will look like. So from down, you have three vessels which emerge, the posterior tibial, antitibial, and peroneal vein. And at the back of your knee, it will all these three together will form as popliteal vein. When your popliteal vein enters into the adductor canal, it is named as a femoral vein. And femoral vein, when it is joined by the saphenous vein and deep femoral vein, it's like a common femoral vein. So to identify DVT, you need to screen these 3 to 4 veins on both the limbs, and that will give you. And this figure will summarize, little clumsy figure. But where to check for these veins? You can start from the common femoral, go down to identify the thrombus in saphenous veins or femoral vein, and finally you check it at the popliteal vein. In the popliteal vein, you will have an trifurcation where you will have an peroneal, antitibial, and posterior tibial, and behind that will be the popliteal artery. How to identify it is like a DVT. It's like a direct visualization of thrombus, non-compressibility, and the loss of flow in the curl Doppler. But sometimes the false positive result can happen. Most likely in case of femoral, when you check for the common femoral, your lymph node will look like an vein which is thrombused. So exactly, there is a small vessel which supplies to the lymph node. You can identify that. In the popliteal vein, you have in elderlies, you have something called as Baker's cyst, which will look like an exactly black shadow, anechoic shadow, which can be misidentified as a vein. And lymph node I mentioned, sometimes there is a pseudoaneurysm. So you need to identify that. And in groin hematomas also, you look like it with the vessels will look like an thrombosed veins. So in nutshell, in case of pulmonary embolism, you should have the indications, strong suspicion about that. You check for the RV dilatation. As Amol sir mentioned, RV is more than LV, ideally measured at the end of diastole. TAPSE, you apical four-chamber view, you put in an M mode at the tricuspid annulus and measure the systolic excursion of that annulus. McConnell sign, again, most specific. And septal flattening will tell you about the hemodynamic instability because of that. Limitation, negative study doesn't rule out the PE. We need to add up the clinical findings along with echo findings. It requires good acoustic window, and sometimes your chronic core pulmonal can also interfere with the with your flow gradients. So sometimes with core pulmonal, you will have a higher higher RV pressure, so it might get confused with the pulmonary embolism. Moving to the next case. So can someone try to find out what could be the diagnosis? The 65-year-old diabetic had a chest pain, hypotension, BP 78/50. Extremities are cold. He has got bilateral crepitations. Troponins are elevated. There are some ECG changes. ACS, cardiogenic shock, MI. Okay. So bang on, likely to be cardiogenic shock. So for an intensivist, cardiogenic shock, our ultrasound focus is generally we focus too much on finding RWMA. Our focus should be to assess for the RWMA, check for whether LV systolic functions is preserved or reduced. You need to look for the complications of myocardial infarction and check the IVCs whether we have some space to give the fluids or not. So traditionally, if you know, this is the 17 segment model of the American Society of Echocardiography. See, if I say anterior wall hypokinesia, it doesn't exactly tells you where exactly anterior wall. So what the ASE has come up with this 17 segment model. So when you look at the parasternal short axis and you direct your probe to the apex. So what you see at the apex is a small opening which will have an 5 components, 5 areas. So it has got an apex. So apical anterior, apical septal, apical inferior, and apical lateral, and so on. This is at the apex. Then the second circle is at the papillary muscles. And the third circle is at the base, that the mitral valve area. So why so much of fuss, why so much of numbers to be given? It is to standardize wall motion reporting. So which area of the heart LV has been compromised? It gives you it is more of an objective description rather than vague subjective. So if I say anterior wall, either it could be area 13, area 7, or area 1. So in general, left anterior descending supplies anterior wall, anterior septum, and the apex. Right coronary artery, it supplies the inferior wall, basal, inferoseptum, and the RV. And the left circumflex supplies the lateral wall of the heart. So we'll just go through this is not an ideal apical view as such. You're not able to see the apex, but it is close to the apex. So you can identify and decide which is the apex, septum, inferior wall, or the lateral wall. So you can identify the hypokinesia at any point of time. So this is at the apical level. And we have got the anterolateral and the posterior immediate papillary muscle. We just tilt the probe towards upsize rather than apex. It is looking directly almost perpendicular to the chest. So you'll have the papillary muscles. So here you can measure and try to find out whether in mid areas of the LV you have got any regional wall motion abnormalities. So either anterior, anteroseptal, inferoseptal, inferior, inferolateral, and so on. And the third area is at the mitral valve or the base, where you will find out which area, and you will label accordingly, just to make it very clear and standardize which areas, which area number has been involved into the regional wall motion abnormalities. So these are few of the examples how it looks like. I think if you have you had your hands on the probe, you'll be able to identify. On the one side, it is different views. So we can clearly see the apex is not moving here. In the second one, it's parasternal short axis at the mid papillary level, and what you can observe is pointer. Okay, fine. I'll take it. So this area, just focus on this area. It is hypokinetic. So that's an anterolateral hypokinesia. While in the third figure, you can see it an anterior wall, just above the, medial lateral to the septum, it is hypokinetic. So this is eyeballing sort of thing. You can identify the things accordingly. So in the lower figure, you can see the inferior wall. It's again the parasternal short axis where the inferior wall is hypokinetic, and in the other, you can observe that the lateral wall, this area is little compromise. Lateral wall. Okay. So this was a bit about the regional wall abnormalities. If we are assessing the EF, as Amol sir mentioned, EF calculations are not generally the part of intensivist. We should focus more of an identifying the LV systolic function. So we'll go, I'll just take you through what are the methods to identify the ejection fraction. The commonest being the easiest one to the difficult, the less commonly followed in ICU. So the visual estimation comes with the experience. So as you see more and more echoes, you'll be able to identify what could be the ejection fraction. It's like an observing the systolic wall thickenings, and no measurements are required. And if it is previously known EF, we are able to calculate it easily. So normal is around 55 to 70. In case of sepsis or others, it's in hyperdynamic circulation. The EF will be more than 70. I'll take you through the various images of the EF. So the first one is, it looks like normal EF. So both rather LV is contracting very nicely, and it can be visualized in parasternal short axis as well as apical four chambers. And the second is like an hyperdynamic. You can see completely LV is completely collapsed in the short axis. While the third one is ejection fraction is definitely reduced. It's a brainer, common sense. So, and in the fourth one, it's very severely depressed LV. So eyeballing, it comes with an experience and it's a rough estimate of ejection fraction. Second was fractional shortening. It is like an M mode assessment of the LV. It can be done in parasternal long axis as well as short axis, commonly done in short axis. So in parasternal short axis at the level of papillary muscles, we put on an M mode and measure the LV dimension during the diastole as well as systole. So it will come like this. And diastolic diameter will be the largest and the systolic will be the smallest. And with that, you can calculate the fractional shortening, and there is a table of what fractional shortening correspond to the ejection fraction. So normal fractional shortening are 20-40%, and it correspond to EF of around 55 to 60%. The fractional shortening, if it is less than 20, it will indicate the reduced ejection fraction. This is the easiest and the easiest objective measurement of the ejection fraction. So this is an parasternal long axis view, where you identify the mitral leaflet. At the tip of mitral leaflet, you put in an M mode, which will cut through the septum. Now, if the ejection fraction is good, the heart is vigorously contracting, your septum will come close to the mitral wall at the end of systole. So that will indicate the distance between the leaflet of mitral wall and the septum at the end of systole will be minimum. That indicates the ejection fraction is good. As opposed, if the ejection fraction is very poor, the septum will not come close to the mitral leaflet, or the false positive can come because of the diseases of the mitral wall. The septum will not come close to the mitral leaflet at the end of systole. The difference between the E wave, which is measured with the Doppler, and the septum, if it is more than 8, it indicates the ejection fraction is reduced. So normally it is less than 7 millimeters. So if it is more than 8, it indicates ejection fraction is reduced. The rough estimation we can calculate, it's like 75 minus 2.5 into EPSS. That's called an endpoint septal separation. How mitral leaflet is separated from the septum. And finally, and the rather most accurate way to identify the systolic function is by the Simpson's method. It's a biplane method. You take the dimensions during systole and systole and diastole in apical 4-chamber as well as 2-chamber. You feed it to the machine and it will calculate and average out both the planes and give you the estimate of the ejection fraction. What ideally, when you take the echo readings of the ejection fraction, when you calculate, it's better to have the ECG leads which are connected to the machine, echo machine. So that way you will be able to identify which is the systole and which is the end of the diastole. Generally, diastole is the largest dimension, systole is the smallest dimension, but it is always good to have the ECG connected to the waves. I won't go much into the detail of the IVC assessment. Dr. Amol has elaborated very well in those. One is completely distended IVC, other one is the collapsible. And you measure these things that has been already covered. Let's come to the third and last case. So can someone come with the diagnosis? It's like this was an observed case around 2 weeks back. This 55-year-old gentleman was posted for EP study and ablation. The procedure was going on fine. And suddenly the cardiologist noticed hypotension and extremities were cold. ECG was small complexes. And when he looked at the patient, the JVP was elevated. What could be the diagnosis? Tamponade. Okay, so likely it is tamponade. Dr. Amol had touched upon this. So it is like an swinging heart into the pericardial cavity. So you have this kind of view with this apical 4-chamber. You can get the similar view in the subcostal area also. And this is parasternal long axis where you can make it out the RV collapse, but sometimes it becomes very difficult. So when the pressure gets equalized and the RV free wall, which is low, RV is a low pressure system, it gets compressed during the diastole. So how do you identify? So it is little difficult to find out which is systole and which is diastole. So you can, it's not running. You can actually reduce the speed of your tracing and you can clearly see that LV is distended. That's the diastole, and at the same time the RV which should have been distended, largest diameter, it is completely collapsed. So that is one point. That is, if not every pericardial effusion is an tamponade. So when there is a diastolic collapse of the RV, that is tamponade. At the same time, your right atrium is collapsed during the systole, which probably it should have been distended during the diastole. It is collapsed during the systole. So these are the couple of findings which will tell you about the RV collapse. So it can be identified like you put in an, again, you can put in an M mode and check for the M mode velocity. So this is an area which indicates the diastole. And at the diastole, you have a pericardium, and during the diastole, your RV wall is going inside. That indicates the RV is collapsing during the diastole. In the treatment, it becomes as early as you need to do an pericardiocentesis. It can be done from an apical window or the subcostal window, which will be little risky to find out whether the liver comes into, or sometimes stomach comes into the play. Or some of the people, they are more comfortable with the parasternal approach also. But when you're putting the catheter, when you're putting the pigtail, make sure that it is in the most dependent, that is the posterior part of the pericardium, so that it will drain out the fluid as much as it can be. So this was with the cases. Takeaway, it's an essential skill for the all intensive. It's like a stethoscope for the intensivists. It can differentiate the shocks at the bedside, and it is likely to avoid the reflex fluid loading, and it can identify the need for the vasopressors or the inotropes. At the same time, keep it in mind, echo doesn't rule out everything immediately. It rules in. If it is there, it is likely to be there. So negative study, it's like an suspicion. You check it again and again to give you the better results. Thank you very much. So you can reach me on these mail or the phone number in case you have any queries apart from what we will discuss it right now.
Thank you, Prashant,
Thank you.
for really beautiful videos and really beautiful insight. I think we have covered most commonly the kind of problems that we encounter as far as echocardiography is covered, both theoretically, practically, and how we should approach. There could have been much more areas which I asked him not to cover, which we will cover in some other section where we will approach the shock and where we will approach the protocols. So that is why we have not covered it here. In the later sections, we will definitely cover this. Any more questions from any side? Dr. Florence, you want to add to something?
I think very nice, actually. I think this is how it should have been. Perfectly but done by Dr. Amol and Dr. Prashant. I don't think we don't need more than this. Okay. So just appropriate. Very nice. Dr. Amol, Dr. Prashant, amazing. Thank you so much. And thank you, Sandeep, for arranging such a beautiful lecture. Yeah.
So before concluding, any more questions from anyone? I think this is the right opportunity. We have some wonderful.
Yes, sir. Yes, sir.
Okay, go ahead.
Sir, I'm a first year resident DM Critical Care, sir, recently joined. So I'm very much interested, sir. Some of the questions that rise in the ICU while working in the ICU, sir.
Right.
Sir, sometimes we see patients, sir, like whether it is TBI, whether it is ARDS, or even core pulmonary patients, COPD patients who land up in sepsis. Sir, sometimes they develop PT, but that's a suspected PT. For example, certainly in the night, they develop hypotension and all that, and eventually they die. So we suspect PT, sir. Sir, what would be the? I mean, echo. The sensitivity of echo is not very high, so we cannot, order D-dimers and other things urgently. So what would be the best approach, like, via echo, so that we can thrombolize the patients? What would be the actual approach? Whether it will be biochemical or other things or clinically. Suppose if we find DVT in some patient, then definitely, yeah, we will suspect it as PT, sir. But sometimes we don't. But still, the picture on echo, like this bowing of the meconial sign, we always don't get. But these D signs and all that we do get, but we are not like sure that we should thrombolize the patients. So we do that medical, this medicine consultation and other consultation. Obviously, they don't do anything, but eventually we lose the patient. But I have seen that sometimes we lose PT patients. We don't thrombolize them, sir. So what should be our approach? Like, yeah, by echo, like, yeah, this is PT, sir. What should be our, sometimes in emergency, sir? Like when we are at the night duties, for example.
Got your point. Got your point. So Prashant, would
Yes,
you like
sir.
to take that question?
Yes, the first thing we need to have a high index of suspicion and echo. See, the thing is, we don't always require a CT scan to diagnose and treat pulmonary embolism. Echo findings with a combination of all these things: RV strain, D-shaped, mecanals with hemodynamic instability, and 60-60 sign, it's good enough to consider for the pulmonary embolism. But at the same time, we need to identify there is no other reason, obvious reason to which can be attributed to the shock. Third, to decide about whether to thrombolize, if you are aware about, around couple of months back, the HS come up with the new classifications for the pulmonary embolisms, like an A, B, C, and D and E categories. So if it is C3 beyond, it is likely to be high risk pulmonary embolism and you can consider for the thrombolysis. I think good enough to have an echocardiography with a high index of suspicion. Along with, if you are doubtful about the echocardiography feature, it clearly rules out, if at all, it clearly rules out, and if you feel that there is a DVT, which we need to screen also. If it is there, and it will have a more diagnostic value to your pulmonary embolism finding.
if I may add to this,
Yeah.
Yes.
so the approach should be different in a patient who is in ICU for last 4 or 5 days and now patient is in shock versus a patient who comes to hospital or ED with hypotension. So I didn't get the name of the person who asked this question, and was the question related to the someone coming to ED or ICU or
So
someone
his
in a chronic?
question, Amol, his question specifically is that if we have a patient who already has core pulmonary, where the
Okay.
findings of echo would be confounding,
Yeah.
and there is a possibility of P, and the
Okay.
patient is in shock, then how to approach that patient? So a patient with core pulmonary may have a
Oh,
massive P and worsen, and which thrombolysis could have saved. I think that is the specific question.
okay. So maybe you're talking about a patient who is already in ICU, probably.
Yes.
I think, should I add something on this?
Okay. Okay.
Yes.
I think there is, I believe there is some recent guideline of the European Society of Cardiology and American Heart Association, wherein they state that if the patient has got cardiac arrest in an ICU, and if there is a high suspicion of pulmonary embolism, okay, and if you don't think that there is any other cause for cardiac arrest, and by doing whatever is possible there through your clinical examination or through your echocardiography, there's a clinical probability, there is shock physiology, or there is evidence of acute right ventricular failure which was not there earlier, or other differentials are excluded. And if you think that there's going to be a risk benefit by doing thrombolysis, if there is no contraindication, the AHA, European Society of Cardiology and American Heart Association, actually say that go ahead with thrombolysis because you're anyway losing the patient.
See, in cardiac arrest, we have no other
Yeah.
option left. Patient anyway dying. So I think the
Yeah.
decision is not as difficult in cardiac arrest. The question arises when the patient is already in core pulmonary. And as this question is mentioned, like ICU day 4, having signs of PT. So I didn't get what do you mean by signs of PT? Because whatever signs of PT you say, so it like ETCO2, PCO2 gap, that is not specific to PT. RAIO dilatation, that is not specific to PT. McConnell sign is not specific to PT. And I guess the patient is in ICU since last 4 days. Obviously, the patient would be on some form of DVT prophylaxis, either chemical or mechanical, and in high risk, both. Again, sudden hypotension, there are many, many reasons of sudden hypotension, and we should not be fixated to pulmonary embolism here. And if anyway, if we strongly suspect pulmonary embolism, I think we should make all the attempts of doing a CT pulmonary CT
PA.
scan, CT with contrast, to identify a massive PE. So we're not talking about any PE, segmental, subsegmental. We're only talking about, when we talk about thrombolysis, we're talking about a massive PE, which is in the proximal vessels like main pulmonary trunk or right or left pulmonary artery, which is causing obstructive shock. If you're talking about a small thrombus in the periphery, that will cause some ETCO2 gradient, that will cause some high D dimer, but that is not killing the patient. What kills the patient is a massive P. And I think if the patient already has core pulmonary, then I think the diagnosis will be more likely to be a core pulmonary rather than a P. It's unlikely to be P, if I would say. Means I will look for, in fact, I will look for other causes of shock. And if I still feel that P is likely, I'll make all my attempts to look for to do a CT scan to rule out pulmonary embolism. Secondly, I'll also look at the contraindications of thrombolysis. Because if I anyway cannot thrombolize this patient because of some contraindication, I can just do anticoagulation bedside. I don't have to send the patient to CT scan. Because the benefit of CT is by doing thrombolysis. And if you are not able to thrombolize after CT, then you might as well just anticoagulate this patient. So can increasing RVSP guide? No. Increasing RVSP guide need of. So there are many confounding factors in this. So as I said, P cannot be, you cannot diagnose P. If you, the diagnosis of P is by CT scan. And not all PE needs thrombolysis. Only the massive PE with shock needs thrombolysis. And the gray area is submassive PE with dilated RARV with raised troponin. Rest all can be managed with only anticoagulation.
So this the indication for thrombolysis is hemodynamic instability. It's not like an RVSP which is increasing. Definitely.
Anyways, it is going to be
Increasing
difficult to diagnose.
troponin.
It is going to be difficult to make a diagnosis of PE based on echo if the patient is in shock. Yes, it is definitely going to be difficult. So that is definitely there. But I think the right approach would be how likely is the P and what is the condition of the patient. If the patient is in shock, there are VTs, there are no other reason, and the P becomes more likely than any other reason. I think it is reasonable to go for thrombolysis rather than not doing it. If I have understood your question correctly.
Yeah, I think I even agree with you, Sandeep, because when I went through the recent European guidelines, it states that an unstable patient with shock and acute right ventricular failure on echo should be presumed P until proven otherwise in the presence of the clinical context. And if that patient arrests, go ahead with thrombolysis.
So Dr. Flores, you are absolutely right. The key word here is acute.
Acute, yeah. Keyword here is acute, right? Exactly. Keyword here is
Because if you have a patient who didn't have a rise in, have a very high pulmonary artery pressure, now he has sudden acute rise in PA pressure, you have a reasonable suspicion. But if the
Yes.
patient is already having core pulmonary, patient having ARD, bad ARDS,
Yes,
then in
yes.
this patient you already have a
Becomes
chronic
difficult.
rise in right atrial pressure, ventricular pressure. So in this patient, it's very difficult to diagnose P.
Any more
I think
questions?
that's nice. I think that's quite an interesting thing. I think any more questions from the audience? I think let's call it a day, right?
Yes. So I would at the end like to again thank Amol and Prashant for their time and their wonderful insights. I think all of us have learned a lot. And so stay tuned, and you can keep on joining this WhatsApp group that we have made for easily communicating with you. So we will be coming up with next session, maybe in 10-15 days time, on the use of use of ultrasonography in critical care. And most likely it is going to be based on the lung ultrasonography. Okay, so stay tuned and we will meet soon.
Good night.
Good night, everyone.
Good
And
night.
thank you, Amol, and thank you, Prashant.
Thanks, Sandeep.
Yeah. Thank you, Amol. Thank you, Prashant. Good night.
Good
Good
night.
night.